view. Yes.
Yes, so this is the lateral view of the left elbow joint, where I can see elevation of the anterior elbow fat pad, and the posterior fat pad is visible, which indicate left elbow joint effusion. Here I can't see the fracture well, but in light of the previously seen images, the most likely diagnosis is left radial hip fracture that is intra-articular and causing elbow effusion. I'll urgently alert the referring physician about the finding and refer patient for orthopedic team for fixation and management.
Okay. I think you can use the mouse now. Can you? Okay, but for this case you don't require the mouse. Okay. You can go ahead with the description.
Okay, so this is a AP view of the hand X-ray of an adult patient. I can see the right or left marker. However, there is a lucent lesion, lytic lesion within the middle phalanx of the second finger. And along with the diffuse acro-osteolysis involving the distal phalanges, and there is also industrial scalloping seen at the radial margin of the middle phalanges of the fourth fingers. That indicates most likely the findings are those of hyperparathyroidism with industrial scalloping, brown tumor, and acro-osteolysis. There is no soft tissue calcification, no vascular calcification that I can identify to suggest secondary hyperparathyroidism. There is osteopenia, diffuse osteopenia of the bone as well. And in my normal practice, I'll compare with the previous images of the patient and with the history of the patient as well. If it's a new case, I'll recommend correlation with the with the parathyroid hormone level and ultrasound scan for the thyroid and parathyroid region. And I'll check clinically why the patient did come and if there is any localized pain or what is the clinical concern. However, I can't see any fracture here.
Okay, there is no fracture. I'll show you the next case. This is your third case.
Okay, so this is a chest X-ray for a skeletally mature patient, frontal view, epi-erect view. There is multiple diffuse bilateral well-defined nodules seen in both lung fields with no zonal predilection, and they appear dense, likely calcified, likely represent a previous varicella infection or histoplasmosis infection. I'll compare with the previous images. There is no suspicious lung masses other than these, and there is no unremarkable rest of scan with no bone lesion. So I'll compare with the previous images and with the clinical history of the patient if there is any history of varicella exposure.
Okay, so
and there's no need for management. They will stay forever. Lesion.
Okay, so what are the other causes of calcified lung nodules that you know of? I agree with one of the differentials being varicella.
Yeah, it could be also histoplasmosis. Yeah, histoplasmosis, but it's unlikely in our region. It's usually affect South America. Also, it could be previous TB with healed calcified granulomas. They also could represent metastasis, calcified metastasis, if there is any non-primary.
So what are the causes of calcified lung metastasis that you know of? What are the causes?
Yeah, I think osteosarcoma metastasis cause calcified lesion. Also, mucinous cancers cause, like mucinous colon cancer, usually can cause calcified lung metastasis.
Okay.
Also, mucinous ovarian cancers can cause calcified, however, less likely.
Okay. So this is your next case.
Okay, I'm presented with a bone scan, delayed images bone scan, anterior and posterior view of an adult patient. where I can see I can't see any shadow within the kidney. Sorry, there is no uptake, reducer uptake within the kidneys bilaterally, which indicates super scan. And there is homogeneous diffused reducer uptake within the appendicular skeleton and the mandible and the skull. No focal reducer uptake or masses that I can see. So for differential diagnosis, that for this super scan could be metabolic or less likely metastasis. It is not affecting the axial skeleton and there is no focal masses. It's homogeneous. So I'll think of metabolic causes with renal osteodystrophy on my top of differential diagnosis and Paget disease. There's uptake within the mandible, which could represent Lincoln sign of Paget disease as well. In my normal practice, I'll compare with the X-ray images of the patient and the previous images as well, and with a history.
Okay, so I will show you some of the radiographs that you wanted. Here is one of them.
Okay, so this is the lateral skull X-ray for the same adult patient, where I can see multiple lytic lesions involving the skull vault, which are small in size, and these are likely they resemble the salt and pepper appearance, which indicate hyperparathyroidism secondary to renal osteodystrophy that's causing the super scan. There is calvarial thickening as well, which could be due to treatment. Yes. So it's likely to represent secondary hyperparathyroidism to a renal osteodystrophy. And this is the lateral X-ray. The lateral X-ray of the lumbosacral region, which there is a calcified lesion within the pelvis, which resembles the shape of kidney, which could represent a calcified renal transplant, which is not working, and secondary osteodystrophy. There is no definite Ricard-Jersey spine appearance. However, there is scalloping of the superior and inferior endoplates of the vertebrae that could represent codfish vertebra, which is associated with renal osteodystrophy. This is the pelvis X-ray AP view of the same patient. Again, seeing the calcified pelvic mass within the right iliac region that could represent renal calcified renal transplant. And there is asymmetrical sacroiliitis affecting the right sacroiliac joint. And there is multiple radiolucencies within the pelvic region. These could represent fecal material. However, they could represent urinary bladder stones.
Okay, ignore those. Ignore those. What about the bones, the pelvic bones?
There is diffuse osteopenia of the bone with the trabeculation, prominent trabeculation, secondary to the osteopenia, I think, rather than Paget disease, less likely Paget disease. And there is lytic lesion within the proximal right femur.
Where? Could you point it out to us?
This with which causing endosteal scalloping and
we cannot,
expansion.
You have to control the screen. Yeah, now. Which one are you referring to? No, just ignore that. That's a pseudo lesion. And you referred to something being a calcified transplant kidney. Could you point that out to us?
Yeah. Yes, this one.
Okay, so what is your final diagnosis combining the findings in the bone scan as well as these 3 radiographs?
Okay, so this is a case of renal osteodystrophy secondary to failed renal transplant and secondary hyperparathyroidism with salt and pepper lytic lesions within the skull and vertebral changes and renal super scan. So I'll correlate with the history of the patient and the clinical concern of the acute, if there is any acute symptoms, and refer patient for the nephrology team.
Okay. Have a look at this case, please. This kid was brought to us at the accident and emergency department.
Okay. This is a baby crown of a skeletal immature patient where there is of the chest and abdomen. There is radio opaque triangular well-defined round well-defined dense structure that is seen projecting over the mediastinum. That's taking a anterior a coronal orientation, which indicates foreign body likely within the esophagus rather than the trachea. And I can't see any lung masses, asymmetry within the lung fields bilaterally, or any evidence of air trapping. However, there is distension of the bowel loops with no definite direct obstruction. In my normal practice, I'd like to see if there is any other lateral view to confirm the position of the foreign body, the suspected foreign body, and also I'll correlate with the history of the patient.
Okay,
yes,
just before having a look at this radiograph, we'll go back to the previous one. On the frontal radiograph, you said that this is more likely to be in the esophagus rather than in the trachea. How do you differentiate these two?
Yes, if it is taking an anterior and a coronal orientation, it will be in the esophagus. If it's taking a sagittal where it's long, its diameter, it should be from right to left to be in the esophagus. If it is anterior posterior,
okay, so
like if it's flipped,
you said that if it's taking a coronal view, it's likely to be in the esophagus. I
yes.
want you to complete the sentence. If it is taking a coronal view picture on which view? On the frontal view or the lateral?
On the frontal view.
Okay, you can have a look at the lateral radiograph here.
Yes, the lateral radiograph is cervical lateral radiograph of the cervical spine. It's showing the foreign body within the posterior to the trachea. So it confirms that it is within the esophagus, and it's rounded likely to represent a coin, entrapped coin within the esophagus. So this is an urgent finding. I'll correlate with the history of the patient and alert the referring physician about the presence of foreign body. It's likely needed urgent management that it will not go down because it's entrapped within the esophagus.
Okay. You will have to scroll through this case. Go ahead.
Okay. So this is a abdomen and pelvis CT scan axial images with contrast. There is in the portovenous phase there is large heterogeneous density lesion within the right, the left. So was the left rectus muscle that extend along the whole left rectus muscle. It appear heterogeneous in attenuation with foci of hyper dense material that could represent contrast extravasation. It's likely to represent rectus sheath hematoma with active extravasation, active bleeding. However, I can't see any subcutaneous bruising or misty fatty planes anteriorly to suggest trauma. I'd like to correlate also with history of recent surgery that could be the cause. Otherwise, it could be spontaneous hemorrhage due to a thrombolytic cause. There is diverticular disease and no other abnormality seen. So this is an urgent finding as there is active bleeding. I'll pick up the phone and alert the referring physician about the finding and correlate with the hemoglobin level and recommend referral for interventional radiology team for endovascular for thrombolysis.
Okay, perfect. So I think your time is over. Very well done. You were almost perfect in all the cases. All the diagnoses were reached by you. Just before I give you the feedback and discuss the cases, in this particular case, this is definitely a rectus sheath hematoma. What 3 histories would you ask the clinician or the patient in this particular case? Give me at least
trauma.
3 histories.
Trauma and surgery, recent surgery.
Okay.
And also, if the patient is on medication, thrombolytic medication.
Good, perfect. So you have to take the history of any direct or indirect trauma. That is the first one. Then any blood disorder, and the
Mm-hmm.
third being any history of anticoagulation therapy. So that is a medication, and maybe you can add the fourth one which you did. That is any recent surgery. So iatrogenic causes are also one of the causes in this
Yeah.
particular case. And actually, I'll just I'll give you the feedback from this case, and we'll go back. So
Yeah.
rectus sheath hematoma actually has a CD classification. It is classified into type 1, 2 and 3. I would not recommend everyone to memorize it. You can go through it on Radiopedia and maybe have a quick glance through it. I don't think it's within the scope of FRCR 2B exams. But regarding the management, what I've understood from my reading is at FRCR 2B level, to manage this case, you would tell the clinician, first of all, you will urgently refer this patient, and then the management depends on the stability of the patient. If the patient is hemodynamically stable, the clinicians might do a conservative management, and if the patient is unstable hemodynamically, they'll manage the patient quite intensively. So that is management part of it. In this particular case, you definitely have active extravasation, so this definitely won't be managed conservatively. So this needs intervention, and referral to the interventional team is a must in this particular case. And there was also a left renal cyst. Candidate 1, could you please leave the mouse?
Yeah.
Yeah. So very well done. You did perfectly in all the cases. This is the first case I showed you the frontal view, and you quickly clicked out there was something wrong with the radial head, even though that might be controversial. Like I might agree, some might not agree, but then you were correct in asking for the lateral view, and this is a very common question in the FRCR exams. If you can't get this in the rapids also, I'm sure you people would be preparing for the rapids, and I will just show for those who are who have started preparing. This is the anterior fat pad sign, that is the sale sign. So in case of, just a moment, yeah, please bear with me, I think there are too many tabs open. So in case of a normal x-ray of the elbow, the lateral view, the anterior fat pad is only visible and the posterior fat pad will not be visible. So, and it will be closely approximated to the distal or the lower humerus, and the posterior fat pad will not be visible. However, when there is effusion, what it does, that the effusion lifts up the anterior fat pad and it becomes a sail. It reminds us of the sail of a yacht or a boat. So the anterior fat pad is elevated, and then the posterior fat pad is also visible as a result of the effusion. So this you have to remember. I'll just close my tab. Then we come on to the second case. This also perfectly done, 8 out of 8 in this case. There's subperiosteal reaction along the radial aspects of multiple phalanges of the fingers, and this was definitely a brown tumor. You described it well. Your description is good. So whenever there's a bony lesion, described the lesion properly. You can either go from the center and the peripherally, whether it's well defined or not, whether it reaches the joint or not, if it has a narrow or a wide zone of transition associated soft tissue tumor or swelling or not, whether it causes any cortical disruption or breakage, and then you have to speak about the matrix also. So all these things you have to describe in almost all the tumors that you see, even if it's a benign looking tumor as in this one. So this is a brown tumor with subperiosteal resorption, and this is a case of hyperparathyroidism. This is spotted in most radiology board exams, so you have to know this. And this again very well done. This was a case of varicella, healed varicella pneumonia. I like the fact that you described the density of the lesions as well. So you were quick enough to say that these definitely look like the density of the adjacent bones, so these must be calcified and most likely varicella pneumonia. So perfectly done. And the differentials of calcifying pulmonary metastasis, which I asked, you all can go and have a look at this mnemonic on Radiopedia. This is very important for any exam. So it's called Bobcat, a good mnemonic, calcifying pulmonary metastasis. I think you gave us half of these differentials. So you said osteosarcoma, ovary, a few others you said. I will share this on the groups as well, so need not worry. Let me just minimize this again, and then and the next case that we gave you, that I gave you in fact, was a bone scan of this patient. This is a super scan, quickly identified that there is no tracer uptake seen in the kidneys, so this is most likely a super scan, and well done in identifying that there is a homogeneous uptake in the rest of the bones, and the distal appendicular skeleton is also taking good tracer uptake, so there is very homogeneous kind of uptake, so this differentiates it from a metastatic bone scan. This definitely is a metabolic bone scan. And then you were shown the radiographs, again salt and pepper, skull, well identified, the calcified transplant kidney, so this was a case of renal osteodystrophy. And this case again very well done, you were correct in everything that you were asked. So this is a foreign body in the esophagus, this has to be quickly referred and this has to be extracted out. So what I will do, I think I have a lot of tabs open, I just close some of the tabs and it makes things easier for me and the rest of us. Again, I think we've discussed this case, right? Candidate 1?
Yes.
We've already discussed this. So you were almost perfect. I would give you a 7.5 out of 8 in the viva. So you are clear, confident, your descriptions are perfect, your speed is optimal and your knowledge is very good. So well done, keep it up and keep practicing.
Thank you, sir.
Yeah. So, yeah, Dr. Vikas Gupta, yes, desmoid is a differential, but then you could see active extravasation in that. You will not see that in a desmoid. And this is a bit hyperdense. In normal practice, we will definitely look at the Hounsfield units. Any other comments? Ask for plain films to make that the lesion is not enhancing. Yes, so we can ask for the plain images to make sure that the lesion is not enhancing. That can be done. But in this particular case, you could clearly see that there is active extravasation. So that was a giveaway. So candidate 1, well done. I will just start sharing the rest of the cases, but before that I will, yeah, this is an emergency, Dr. Amna. This has to be, yes, even if it doesn't have active bleed, you have to treat it or manage it as an emergency, because the patient might be clinically unstable, hemodynamically unstable, so that depends. You, as a radiologist, we sometimes might not know the entire thing. So even if it is not an active bleed, not an active extravasation, you for exam purposes, at least for 2B purposes, treat it as an emergency. Candidate 2, I'm just looking for you, asked to unmute. I think, yeah. Candidate 2?
Hi.
Yeah, hi. So
Yes,
you're here, right? So just start the timer and then we'll give you 15 minutes. Then you can begin. So I think I've started the timer, I've closed this, and here is your first case. Please go ahead.
Okay. So I have been provided with a radiograph of a patient, including AP chest and upper abdomen. So I can see that there is dextrocardia as the left ventricle is pointing towards the right side. I'm looking for, since the patient is dextrocardic, I'm looking in the lungs for any abnormality. I can see that there are some reticular opacities in the left lower lobe, which may represent the bronchoectatic changes. However, in my routine practice, I will zoom out these images and I will review them. I can't see any free air in the lung apices.
Okay,
I can
ignore
see
those.
a
Focus on
rounded
this. Focus on
opacity.
this
Yeah,
area.
yes,
Yeah.
yes. Okay, I can see a rounded opacity in the upper abdomen. So I think this is most. I will compare it with the lateral views to confirm whether it is on the surface or whether it's an artifact or it's really inside the abdomen.
Yeah,
And if it is inside the abdomen, mm, it is
so it is
projecting
not
over
an
the lip.
artifact.
Okay. So most likely then this is an ingested foreign body. And based on that, most likely this patient has dextroposition of the rest of the organs as well. As I can see, the liver is anatomically located towards the opposite side, and the spleen is in place of the liver. So most likely this foreign body is lying within the stomach then. I
Okay.
would confirm these findings on the lateral views as well
You can have a
and
look at
get the
this
history
case,
from the
please.
patient. Okay, so I've been provided with a chest radiograph of a skeletally mature female patient. I can see that there are multiple reticulonodular opacities which are dispersed in both lung fields with a predominance in the middle and lower lung zones. Overall, the lung volumes are well preserved. Cardiomediastinal contours are unremarkable. Breast shadows are unremarkable.
Let
I'm
us
looking
focus on
at
the
the,
positive findings first. Yeah.
okay. So, and there are some in the lungs, I can see that there are some cystic lucencies as well in the lower parts of the bilateral lungs, in addition to the reticulonodular opacities. Mm, The lung changes are more marked in the basal areas as compared to the apices. In my normal routine practice, I would confirm, get the clinical history of this patient regarding any occupational exposure or any drug intake.
No such exposure was there.
Okay. Any history of malignancy in this? I will also confirm if this patient has any history of malignancy, and if the previous X-ray is available, I will compare my findings with the previous chest X-ray to look for the interval change.
Okay, previous radiograph was not available.
Okay.
The patient presented to us with dyspnea and minimally productive cough.
Okay. Is there any history of, I would like to consult the patient if there is any history of joint pains or prolonged arthropathy.
No, no such history.
Okay. So these can be on based on these findings, my provisional diagnosis could be the cryptogenic organizing pneumonia.
Okay, so what do you do next?
I would convey my findings to the referring physician and ask to get a CT chest for further evaluation.
Okay, have a look at the CT of this patient. I will give you the control, and then you can start scrolling. I have given you the control. You can accept it and then start scrolling. You can scroll the mouse. Yeah, go ahead.
Yes, yes. Okay, so I've been provided with the CT chest images, and I can see that there is a crazy paving pattern of parenchymal disease, as there are thickened interstitial septa with some areas of air trapping, which is involving bilateral lungs with no specific zonal predilection. So based on these findings, there are relative sparing in the bilateral lung apices. I can't see any pleural effusion or pneumothorax. So based on these findings, I would make the possible differential of cryptogenic bronchiolitis obliterans organizing pneumonia boom, or it could be the other possible differential could be permealveolar proteinosis or chronic hypersensitivity pneumonitis.
Okay,
I will
given me 3
correlate.
or 4 differentials. What is your primary differential out of these 3 or 4 that you gave me?
I think the most likely will be bronchiolitis
Just stop there.
obliterans.
Just stop there. Just stop there.
Organizing
Looking at
pneumonia.
this particular image, this slice, what is
Yes.
your final diagnosis?
This is the crazy paving pattern, typical of crazy paving pattern.
Okay, so what is your diagnosis?
Permealveolar proteinosis.
So good. Okay, so what will be your management in this case? I accept your primary diagnosis and I accept your differentials. So what?
Okay, I will refer this. I will convey my findings to the referring physician and ask them to immediately refer this patient to the pulmonologist and do the required blood tests for this patient. And if possible, bronchoalveolar lavage can be considered if they don't find any other cause.
So if they don't find any other cause, only then bronchoalveolar lavage is to be done, or?
It depends on the condition of the patient, whether the patient can tolerate a bronchoalveolar lavage or not, because it is usually done under anesthesia.
So what is depending the treatment on the of pulmonary alveolar proteinosis?
I think it's a steroid therapy.
Okay, we will go to the next case. You can again scroll and describe it.
Okay. Sorry. Oh, now it's okay. So I have been provided with CT chest views, and I can see that there are coarse interstitial reticular changes, which are more marked in the periphery of the bilateral lungs as well as in the lung bases. In addition, I can see that there are honeycomb changes in the bilateral lung bases with some traction bronchiectasis. I can't see any pleural effusion or pneumothorax. The most striking finding that I can see is that there is a dilated esophagus, which is extending throughout. So this is the hallmark for scleroderma. So based on these observations, the final diagnosis will be UIP, secondary to scleroderma.
So what is UIP?
Usual interstitial pneumonia.
Okay.
I will, in my routine practice, I will get the further history from the patient and ask if there is any previous imaging available for comparison. So since I can see that there is a dilated esophagus and most likely this patient will have history of dysphagia as well, I would ask to get the further workup for scleroderma, including the radiographs for hands.
Okay, have a look at this one, please.
Okay. I have been provided with X-ray chest, and I can see that there is a well-defined opacity in the right upper lung lobe. The rest of the bilateral lungs are unremarkable. There is another opacity with some well-defined opacity in the left upper lobe close to the aortic knuckle.
Where in the left upper lobe? Could you point out to us?
Sorry, not left, in the middle, somewhere, this one.
Left middle lobe here?
No, I'm saying that it's close to the aortic knuckle, this one here, in the hilar region.
You told me that there is an opacity in the left upper lobe?
No, the first opacity, the first opacity is in the right upper lobe. Okay, and there is another, ill-defined, well-defined opacity with some ground glass attenuation in the left hilar region.
Okay,
so otherwise there are
this one. This is not an opacity.
Yeah,
pulmonary vessels. Yeah, focus on this one, please.
Okay, so based on this appearance, my first differential will be maybe it's a permehematoma because it's a very well-defined lesion. However, I will correlate my findings with the chest X-ray and also inquire what was the presenting complaint of the patient for which the X-ray was performed, because the other possible differential could be a malignancy as well.
Okay, you just said that you would correlate this with the chest X-ray. Which chest X-ray? We've already provided you the chest X-ray.
With the previous chest X-ray, if the patient has any
in the previous chest X-ray, the size and the morphology of the lesion was very similar, almost the same.
Okay, so another finding that I can now see that there are some areas of increased density inside the lesion, which may represent some calcific densities. So if this lesion is stable over a period of time, so my first differential will be a permehematoma.
Okay, what would you do next for this pulmonary hematoma?
Yes, so
Okay, I'm not,
as I
suppose
can
I've
see
not
that
shown you the CT, which I did show you. On the
I will,
X-ray, if the
okay,
lesion
I
has
will
not
reassure
changed
the, mhm, right,
size from last year and the lesion
okay.
morphology is roughly the same from last year, no symptoms, what would you do?
Okay, we will just I will ask the referring physician to just reassure the patient and will do nothing.
Okay, good. So have a look at the CT scan. You can scroll and describe.
Yeah, okay. So uh, it's not screw. Okay, now. Sorry. So it's the CT scan of the same patient, and I can see that there is a well-defined soft tissue lesion in the right upper lobe, which is corresponding to the same lesion that I could see on the chest radiograph. In addition, this lesion has some high attenuation areas in a typical popcorn calcification pattern, with some areas of low attenuation, which may represent the fatty areas in this lesion.
Okay, how do you
So
make sure
the
those are fatty lesions?
by measuring the Hounsfield units,
Okay,
like it
good.
should
Go
be
ahead. Yeah.
-30, -40,
Good. Continue.
and the calcium is definitely very high. So the imaging findings are very typical of hematoma. And I will review the rest of the lung fields as well. Although, yeah, now I can. So I think it's a limited view.
Okay,
Yeah,
limited view.
it's only
Okay,
covering the upper
have a look
chest.
at the next case which I show you. This is the next case.
Okay. Okay, so I have been provided with the chest X-ray of a patient. And I can see that there are significant permifibrotic changes in the bilateral lung fields, leading to reduced lung volume, which is more marked on the right side. There is some haziness over the ribs as well as the mediastinal contours that raises the possibility that there is pleural involvement as well. And I'm suspecting that this patient has some chronic interstitial lung disease pattern. There are some cystic lucences as well, which are more pronounced along the middle and the lower lung zones. Bilateral costophrenic angles are a bit hazy, which is most likely due to atelectasis and the fibrotic changes. However, I can't see any free air in the lung apices or in the under the diaphragm. I would like to know about the history of this patient related to the occupational exposure
There's
or
no
any
occupational
previous.
exposure. The patient has chronic cough for the last 1 year, which is deteriorating gradually.
Okay, so I can see that there is some widening of the mediastinal stripe. This may represent the mediastinal adenopathy. So I would like to know if there is any previous chest radiograph for comparison, or if there is any previous history of granulomatous disease like sarcoidosis.
Yeah, we did have a previous radiograph, and compared to the previous radiograph, the findings have increased significantly.
Yeah,
What?
so most likely, yeah. So based on this appearance, my most probable differential would be like the patient is having progressive permifibrosis, which is most likely secondary to some granulomatous disease process. So given that there are the bilateral bulky hyla and some increased left paratracheal stripe, which is obscuring the aortic knuckle as well,
Okay, so
most
how will
likely
you
this patient.
differentiate? How will you come at a final diagnosis? Is the radiograph enough for you to give a
No,
final
I will
diagnosis?
convey. No, I will further ask for chest CT scans, HRCT chest.
Here is your CT scan. I will just scroll to the top. Please leave the mouse and then I will give you control. Now you're good to go. You can start scrolling and describe this particular CT.
Okay. Uh,
You can
it's
just
not
click
moving.
once. Yeah, and start scrolling.
Uh,
Good.
yeah,
Perfect.
sure. Yes. It's yes. Now it started moving. Okay. So I can see that there are some fine reticular changes as well as there are fibrotic bands. There is this honeycomb pattern, which is more pronounced in the periphery as well as in the mid to basal lung regions. So these are all, and there are some bronchiectatic changes as well, which are more marked in the lower lung zones. So these are all findings which are typical of usual interstitial pneumonia, UIP pattern. Now, this is the chronic interstitial lung disease. I would like to change the window to the soft tissue so that I can evaluate if there are any nodes, although I can see that there are the tiny nodes.
Okay, ignore those. So what would you do next? What is the management?
Yeah, so depending on the condition of the patient, I would ask if I would like to know if there is any occupational exposure in
There's
this
no
patient.
occupational exposure. You've already given me your diagnosis of usual interstitial pneumonia. What would you like to do next?
Yes, because the usual interstitial pneumonia is a wide spectrum. It's like the causes are multiple. So I would like to review the causes. Like I would ask if the patient has previous history of rheumatoid arthritis, or if there is a chronic drug exposure, or there is some occupational exposure, or any previous history of hypersensitivity, chronic hypersensitivity pneumonitis. So all these, I mean, I will have to rule out all the multiple causes for this possible UIP.
Okay, so we'll stop here. The time is over. Okay, well done. You are good. You're clear, confident. Your speed is good. But there's few things that you still need to work upon, and we'll go through the cases one by one. And there is still a lot of time, so everyone can still work on their viva presentations and fine tune themselves and prepare in a better way. So just allow me a moment. So first of all, you said this is a case of usual interstitial pneumonia. I accept your diagnosis, which was the diagnosis. So what is this then? You said this is also usual interstitial pneumonia.
This is bronchiectasis more marked in the basal region, so this can be cystic fibrosis.
No, this is not cystic. See, I'll tell you. This was a case of non-specific interstitial pneumonia. So in scleroderma or in systemic sclerosis, it is more associated with NSIP, that is non-specific interstitial pneumonia, rather than UIP pattern. And for exam purposes, avoid giving short forms, avoid giving abbreviations. So maybe some of these abbreviations we commonly use in our practice in India or in our particular countries, wherever you've joined from, but it is not necessary that the UK examiners might be using the same abbreviation. So avoid any abbreviations. Speak out the entire diagnosis, spell it out, talk it out. So non-specific interstitial pneumonia, and there is traction bronchial ectasis. The differentiating factors, the differentiating points between NSIP and UIP are a few. So both of these present with diffuse ground glass changes, bronchial ectasis, but there are few differentiating factors. I think if I remember what I had read from Webb a few years ago,
honeycombing, I think.
Yeah, honeycombing is a hallmark of UIP. So you'll have a lot of honeycombing in UIP, that is this one. So if the honeycombing is more predominant, then the ground glass changes. So in this case, honeycombing is definitely more prominent and predominant than the ground glass changes. So this becomes an UIP. Yeah, Dr. Ahmed Tariq, that can be still be a fibrotic type NSIP. That is not within the scope of FRCR to be vivas. That goes into the scope of the subspecialty of chest radiology in UK. So I don't think it's necessary to go into that kind of subspecialty differential or a diagnosis. So it's okay if you tell UIP or NSIP, that is enough. So this case, rather than saying UIP, you should definitely say that this is an NSIP case. The ground glass changes is more predominant than the honeycombing. I can hardly see any honeycombing. Very few small honeycombing areas are there. And in NSIP, you will definitely also have some areas of subpleural sparing, which you can see over here. Can you appreciate?
Yes, now.
Though it's not very prominent, but there are very thin areas of subpleural sparing, which does not occur in UIP. And then the third differentiating point is that UIP has an apicobasilar gradient. That is, the findings are more marked in the basal segments rather than in the apices. Whereas NSIP tends to have less of this. Although in this case it still has an apicobasilar gradient, but the differentiating points are these three that I remember. If someone else remembers any more differentiating points between these two, please let us know. Yes, the subpleural linear band parallel to the pleura is what I referred to as subpleural areas of sparing, Dr. Shekhawat. So you're correct. So that is basically the same thing. So we've discussed these two cases, and then we come back to this. This was a pulmonary hematoma. You did well in the radiograph as well, but there is something which you keep doing. You stop abruptly and wait for the examiner to tell you something. So contrary to most of our board exams, the radiology vivas that we've been through earlier, some of these examiners, they won't say anything in between unless and until you stop after completing the management. So you will have to do the management and then stop. You cannot stop abruptly and maybe ask the examiner to speak. That is not done. You have to complete every case with the management. So do that. If you are getting a radiograph, ask for the previous radiographs. You did that perfect, but you have a tendency of not asking for the further imaging. So in this, you were very slow in asking for the CT. In this case, I agree that the CT is sometimes not required, but if, yeah, just a moment, candidate 2 says that she has been muted, so we will unmute candidate 2.
Thank you so much.
Yeah, so I agree that you actually, after I told you that the previous radiograph was the same and there was there were no changes in the findings in this particular radiograph, I agree that the CT was not needed, but generally ask for the CT whenever you need it. Even in this case, you went into a loop of describing the findings on the radiograph and did not ask for the CT scan. This is a case of pulmonary alveolar proteinosis. This is crazy paving appearance, interlobular septal thickening and intralobular septal thickening around with ground glass changes. So pulmonary alveolar proteinosis is the primary diagnosis in this case. The treatment of pulmonary alveolar proteinosis is whole lung bronchoalveolar lavage. So that is the standard treatment. So it is not a matter of choice. You have to do this in the case of pulmonary alveolar proteinosis. So you can go back and check on Radiopedia. The standard treatment is therapeutic whole lung bronchoalveolar lavage. They remove the alveolar material, especially in adults, and then they can also give GM-CSF supplementation. So GM-CSF supplementation is basically granulocyte macrophage colony stimulating factor supplement that is given in some of the patients, but bronchoalveolar lavage is the primary treatment of these cases. I just remembered that I did not discuss the radiograph of this UIP, usual interstitial pneumonia case. Well done. I like the fact that you discussed about the lung volume. So in any radiograph, the differentiating point of interstitial lung diseases such as UIP and NSIP and the fibrotic lung diseases and the group of cystic lung diseases such as Langerhans cell histiocytosis and those differentials is lung volume. So in these particular group of cases, that is the fibrotic lung diseases, you will have a reduced lung volume, whereas in that group, the cystic lung diseases, the lung volumes will be maintained. So do remember this. And this is the last case. Okay, very good, dextrocardia, and then you realize very late, but you did, that this is a case of total situs inversus with the foreign body in the stomach. So in FRCR exam, it is very unlikely that you would be given a radiograph or any imaging with an artifact. So if they give you, they'll talk about the artifact, which is still less likely because artifacts have already been covered in FRCR physics. So do not assume that it's an artifact unless they tell you.
Right.
Okay, so overall,
Dr.
well
Sandeep,
done. Yeah.
Yes, I have a question. So, what will be the treatment about UIP and NSIP? What will be the treatment?
The you will refer it to the pulmonologist. The treatment of NSIP is corticosteroids. So NSIP is very responding to corticosteroids, but UIP does not respond to corticosteroids, and then the eventual treatment is lung transplant in UIP. So that is the basic difference. You refer it to the pulmonologist. Most of these cases require a lung biopsy for histopathological confirmation of the diagnosis.
Sure.
So you can
Thank you
get
so
that
much.
done as well. Okay, so we complete the cases for today. And yeah, Dr. Sadav asked, do we have the controls to magnify? Most of the times, majority of the times, 99% of the times, they will not give you a magnified view, because most of these cases are easily diagnosed with the views that are given, and if magnification is needed, they will themselves magnify it. I don't think you asking for it will change the pattern of the viva. So if necessary, ask for it. If this feel that it is necessary for the diagnosis, they might magnify it, but do not expect magnification in the actual exam. So thank you everyone.
Okay.
Most probably we'll meet next Saturday or Sunday, depends on the other sessions as well. I actually wanted to take a session yesterday, but some candidates told me that there is a session by Dr. Sami Khan sir, so that's why we did not have a session yesterday. So maybe next Saturday or Sunday we'll let you know. And I've already added people to the wait list. Whoever has messaged me, if you want your name to be added to the wait list, please send me a direct message. Thank you so much. Good night everyone.
So much.